Perfect. Are you ready to get started?
Yep.
All right, let's do it. Good morning, everybody, and welcome back to Grand Rounds for the Department of Medicine here at Washington University School of Medicine. I'm John Hickman, one of the chief residents. It's my pleasure, as always, to welcome you today. I am very excited about today's speaker. I was thrilled when she agreed to join us, and it's just a real treat to have her. You hear more about her in a moment. As always, we're going to hopefully have some time for questions, so please send them along through the chat and I will moderate them with our speaker as we go. And here to introduce our speaker, we have our very own Dr. Rakhi Bayani. She is the director of the Forum for Women in Medicine and one of our APDs, an assistant professor in the Division of Medical Education. Dr. Bayani, thank you for being here with us today.
Well, thank you. Good morning. I'm really excited to introduce our speaker for today for Grand Rounds. The invitation for Dr. Valerie Stone's visit was issued in partnership with Washington University's Center for the Study of Race, Ethnicity, and Equity, also known as CRE2. The center brings research force of Washington University to study how race and ethnicity are integral to the most complex and challenging issues of our time. So as part of our CRE2 Grand Rounds partnership, I'm pleased to introduce Dr. Valerie Stone, who is the Vice Chair for Diversity, Equity, Inclusion, and the Director of Health Equity Initiatives at the Department of Medicine at Brigham and Women's Hospital. She's an academic internist as well as an HIV/AIDS focused infectious disease specialist. She's a professor of medicine at Harvard Medical School. And of note, when Dr. Stone was promoted to professor of medicine in 2011, she became the first African-American to reach the milestone at Harvard Medical School in its history. She received her medical degree from Yale University and did her internal medicine residency at Case Western. She completed a health services research fellowship at the Harvard T.H. Chan School of Public Health and an infectious disease fellowship at Boston University School of Medicine. She's a nationally recognized expert on HIV and AIDS and is the author of numerous publications. Her research focuses on the disparities in HIV/AIDS care by race, ethnicity, and gender, and strategies for optimizing the care of diverse patients living with HIV and AIDS. Her scholarship has also examined current issues in primary care, diversity in healthcare, and innovations in residency training. She's received numerous awards for exceptional contributions in education, research, advancing diversity in patient care, along with her efforts in faculty development and diversity. So please join me in welcoming Dr. Valerie Stone this morning. Thank you.
Thank you very much, Dr. Bayani. Let me share my screen. Can you all see that?
Looks great.
Okay, great. So I will be speaking to you today on advancing diversity and anti-racism, a framework and strategy for academic departments of medicine. I have no disclosures. So my objectives today are that you will be able to recognize the importance of advancing diversity and inclusion in academic medicine, describe historical trends in diversity in academic medicine, become familiar with an anti-racism conceptual framework and how this strategy has been used to advance diversity and inclusion in another academic department of medicine, obviously ours at the Brigham and Women's Hospital in Boston, and be inspired to implement this strategy in your own department and track your outcomes. So I started medical school at Yale in 1979, what sounds like a very long time ago, and I guess it was. It doesn't feel like that long ago to me. But at that time, there were absolutely no faculty who, quote unquote, looked like me. So what do I mean by that? No Black women faculty. We had one Black male faculty. Here I am with my mom over here in front of Yale New Haven Hospital, you know, and here I am with the group of first years over here on the right. Yale is a place where a lot of medical students end up going into academic medicine. And like so many of them, I was inspired to go into academic medicine. And that's worked out well for me. But as you understand, I saw no role models that made it look that doable. And I was able to get there despite that. But I really expected things might change a lot over time. But in fact, they really have not changed that much. This is data from a paper that came out last week in the New England Journal, which shows the increase in women faculty since approximately when I started medical school. This is tracking from about 1980 to present. And you can see that women now comprise about 45% of faculty, and in the blue bar in the left-sided graph. And over here in the blue bar on the right-sided graph, you can see the increase in minority faculty over time. And the other bars are the percent of minority deans, department chairs, and full professors. So minority faculty now comprise about 9%, that is underrepresented minority faculty comprise about 9% of all academic medicine faculty in the United States. And people like me, full professors who are URIM, comprise about 4.5%. But in fact, things have not changed quite as much as you would think. That same article published by Joan Reed and her colleagues last week in the journal of the New England Journal shows that people who look like me, women, Black women faculty, comprised about 0.5% of academic faculty in 1979 when I started, and now comprise about 1.5% of all minority faculty. Interestingly, Black male faculty, who were about 1.5% of minority faculty when I was in medical school, now are less than 1% of all faculty in the United States in medical schools. And you can see the largest increase in underrepresented minority faculty since that time has been Hispanic men and Hispanic women. And while this is wonderful, it turns out that we underestimate the very slow change in Black faculty since I started medical school. And just in case you're thinking, oh, those numbers really are reflecting the low numbers in fields like surgery or anesthesiology or radiology, I don't know, whatever field you might be thinking of, this is the trend of minority faculty in internal medicine since that time. So you can see all clinical faculty in the light blue going up this way, and all faculty in internal medicine in the orange bar, and they are, as of now, completely aligned with one another. There is no change in the percent of URIM faculty in internal medicine compared to all academic medicine faculty. So why is diversity in academic medicine so challenging? Here's a few thoughts. Many underrepresented minorities are from more disadvantaged backgrounds and therefore often receive suboptimal science education, and thus it may be less likely that they'll go into science fields. This is what we hear most frequently. But what I would say in addition is, whether disadvantaged or not, racism in the environment makes everything more of a struggle for minorities in science and medicine. And certainly I have lived this since I was a child who was particularly gifted in math and science. There's discouraging events and advice along the way leading to a leaky pipeline, meaning people are discouraged and they say, oh, I can't really become a doctor, I'll do something else. Negative assumptions about our knowledge base, intelligence, and work ethic. And as you know, assumptions can often reflect future grades because so much subjectivity goes into grading and evaluations. Microaggressions are a daily burden, as we know, in the hospital, but they happen far earlier than that. Career enhancing networks often exclude minorities, limiting advancement. This starts in high school, maybe earlier. It's tougher to find mentors, and we rarely can find career sponsors. And institutional images of doctors, scientists, and leaders, figuratively and literally, don't look like us. So given all of these challenges, I have been involved in diversity and inclusion on the side for my entire career. And what I mean is, when I was a program director at Mass General, I was doing diversity stuff that was not part of my job all over the place at Harvard Medical School, Mass General, and nationally. And when I was a chair at Mount Auburn, similarly, I was very involved in diversity work because I thought, it needed to be done, and nobody was getting paid to do it at that time. And I really wanted to see things change over time. But things changed for me in 2019. The Brigham and Women's Department of Medicine held a strategic planning process in 2018 and concluded that the failure to make much progress around diversity and inclusion at the Brigham's Department of Medicine resulted in a true need for someone who would be a vice chair for diversity, equity, and inclusion. I was honored to be selected for this new role. I had to change institutions, and I came over to start in this role in July of 2019. Our goal was to build on the outstanding diversity work going on at the Brigham for many years, and most of that diversity work had been in very successful recruitments to many URMs into the residency program. Our vision grew more ambitious to go beyond diversity and inclusion to anti-racism. And my goal today is to describe our journey in the Brigham Department of Medicine and to share my anti-racism conceptual framework, how we've applied that framework in our Department of Medicine at the Brigham, and hopefully to provide you with some inspiration to use any or all of this framework that might be helpful in your department. So people were actually talking about anti-racism in the Department of Medicine at the Brigham when I arrived. My colleagues, Sonia Solomon, Alev Adelaide, and particularly Nora Osman were talking about this maybe earlier than I'd heard others doing it, and provided an outstanding grand rounds that took place my second month at the hospital about diversity not being enough and a need for anti-racism. I mean, and at that time, it felt like a little bit of a new concept to many others in the department, and you know, was not something that everyone embraced right away. However, about 9 months later, following the murder of George Floyd, the entire department became very much activated. And here you can see a picture of the or several pictures of the demonstration that our residents organized for anti-racism, and a demonstration for Black Lives, and the flyers about that. And things really changed, and there really became great energy around anti-racism in our Department of Medicine. Our residents came up with a list of anti-racism priorities that they asked the department and the hospital to move forward. And obviously I can't go through all of them, but they were a wonderful group, and we in fact have done about 2/3 of them at this point. But you can see this as a sense of the energy around anti-racism in our department as of June 2020. We also wrote a lot of papers and tried to energize the country around this and to share our energy and our commitment. So you can see a paper that has become sort of a calling card around providing the right care for the right problem and the inequities that we see about that. A study showing heart failure patients were less likely to be admitted to the heart failure service at the Brigham if they were Black or Latinx. And then 3 papers that we all wrote in our department about the importance of anti-racism and doctors moving in that direction. Work that happened at the time that we kicked off this work. So what does it mean for a department to be anti-racism, and what is anti-racism? So as you all know, racism is a system of structuring opportunity and assigning value based on phenotype, which is what race is, that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and undermines the realization of the full potential of the whole society through the waste of human resources. Anti-racism, therefore, is active involvement in dismantling racism at the many levels at which it exists, from structural racism to institutional racism, interpersonal racism, and dismantling the system of white supremacy. So how can a department become anti-racist, and what are the steps in that process? So as I thought about what we needed to do and what we needed to assemble in order to move this work forward, I came up with this framework that, in order to move forward anti-racism, transformation, we needed committed leadership, culture change, we needed to advance diversity and inclusion, we needed to change policies and practices that made any of this challenging, and we needed to work on advancing health equity for our patients in our community. So I'm going to walk you through each parts of this framework, what we did and how, and show you a lot of pictures of our department and a few reflections on how it went. So first of all, let me talk about committed leadership. In order to move forward with a bold agenda like this, it's critically important that the chair of the department and other Department of Medicine leaders are committed to combating institutional racism and its effect on the clinical, educational, and work environment. The leaders need to be willing to talk about anti-racism as a key departmental and residency priority. They need to understand that this is not just about diversity and inclusion, but becoming anti-racist, which is much more. He or she needs to understand that the burden should not be on underrepresented minority faculty and residents to do this work alone. And the leadership of the department needs to be willing to fund the programs that are necessary to combat racism and transform the environment. Our Department of Medicine leadership, as I told you earlier, prioritized diversity and inclusion during their strategic planning process, and thereby created the Vice Chair for Diversity, Equity, Inclusion, and funding for the associated programs and initiatives. Our chair, Dr. Joseph Lascalzo, made it clear to all that DEI was among his very highest priorities. And as our anti-racism agenda developed, he remained strongly supportive. Again, all of this was a lot bigger than was initially expected. And so his continued support was incredibly important. The Department of Medicine at the Brigham has invested in diversity and anti-racism. Every program that I will describe to you was funded internally, and this financial investment, which is substantial, is a further reflection of leadership. Now, in addition to the departmental leadership being committed, the residency leadership and key faculty leadership commitment is important as well. As you know, in most hospitals, residents of color are dealing with a daily onslaught of upsetting racist incidents. These include microaggressions directed towards them by nurses, patients, faculty, and staff, observing racial inequities in the care provided to patients of color, racist comments about patients of color, especially Black and Latinx patients, racist incidents taking place in their communities and across the nation that make them feel terrorized and traumatized. Given all of this, programs need to have one or more leaders or structures in place within the residency to whom residents of color can turn to for support, validation, and advocacy. Here you see a picture and an article from the New York Times showing one of our fellows in front of our hospital talking about these microaggressions, which are indeed all too familiar. So what was our situation in this regard? So last year we had an exceptional chief resident pictured here, Dr. Evan Shannon, who was instrumental in advancing our work in anti-racism and who was a close partner with me in much of this work last year. This year we have a designated DEI chief resident, Dr. Lauren Malachek, who's also extremely involved. However, we now have an APD as well. Our residents requested an APD for health equity and racial justice. This took a while to operationalize, but I'm excited to say we have an excellent faculty member who was selected, Dr. Margie Louisias, who began in this role and is doing wonderful work since October 2021. Prior to this, we had numerous other faculty, including myself, that the residents knew they could turn to. Our program director, Dr. Joel Katz, has been a consistent champion of DEI work and now of anti-racism work, and has provided substantial funding for some of this work and also time for some of the residency leaders to work in this domain. There have been a lot of good articles written about the ways that we should support URIM residents, but I particularly like this one as we think about the role of leaders. chief residents, APDs, and the program director. So great article that was written by colleagues at Northwestern entitled Towards Inclusion, a guidebook for champion diversity for internal medicine chief medicine residents. So now let's turn to culture change. Unfortunately, like medical schools, our institutional culture and learning environment within academic medical centers are comprised of policies, procedures, and practices which promote and entrench institutional racism. Efforts which recognize this and proactively promote anti-racist culture change are very much needed. And here's a paper written by one of our current interns, Dr. Max Jordan Negwemi, that was published in the Annals of Internal Medicine about 18 months ago about medical schools as racialized organizations, which essentially, all of this mirrors what we see in academic medical centers. So what have we done to sort of change the culture? We've done a lot to have speakers come and talk about anti-racism from a lot of different perspectives and a lot of different places. And I can see you're doing that as well. And infusing this work and this energy into Grand Rounds has made a big difference. In addition, we decided that people really needed something more participatory and interactive. And so we launched a set of anti-racism book discussion groups last year. The Department of Medicine purchased So You Want to Talk About Race, which is pictured here, for every faculty member in our department, and invited all faculty who wanted to participate in a Department of Medicine-wide book discussion group. So we held 10 department-wide book discussion groups, meaning about 15, 20 people in a group, and you would have people, from a number of different divisions in each of those 10 groups. Each discussion group had 2 facilitators and a mix of URIM faculty leaders and people from our hospital diversity and equity office staff helping to lead them. Most divisions also use the book to hold their own book discussion groups. So a total of 24 discussion groups were held across the Department of Medicine. And the faculty really appreciated this opportunity to not just listen, but really talk about race and racism, share and ask questions, and really sort of learn from one another. But we really thought we needed to do more to move the needle and to get faculty leaders and educators thinking about what we could do differently to actually become anti-racist. So we developed a racial justice curriculum, and our goal was to develop a shared language, knowledge, and understanding of history and racism in the US, a shared health equity framework, and to provide a space to share, reflect, and catalyze anti-racist institutional change. So we developed a 2-part racial justice training, which was 3 hours per session, and each person got 2 3-hour sessions. And this was developed in conjunction with the Brigham DEI leadership of the hospital and myself, and delivered between February and May of 2021. We completely filled our capacity. A total of 420 faculty attended in groups of 20. We would have loved to have done all of our faculty. We have well over 1,000 faculty, but we were glad that we could have that many trained. And the division chiefs and vice chairs joined Dr. Lascalzo and I for a special session for the leaders. And all of our residents received a shortened 3-hour version during their class retreats, including the current year's interns, which just had the training last week. I think that these sorts of things are really important, because listening to a talk about anti-racism is good, but having the opportunity to actually interact, ask questions, have some dialogue, and really take it in is incredibly important. So I would really encourage these sorts of anti-racism book discussion groups if you don't have racial justice training. So they're easy to organize in your department or division. The goal is to read books on race, privilege, and anti-racism. And I really think these promote important and necessary dialogues about race, racism, privilege, diversity, and inclusion. One of the key things you want to do are utilize two facilitators for each group and make sure they're experienced. As someone who's done a lot of these groups, my experience is people can say some pretty surprising things, and it's important to be there with someone else who's experienced as you figure out how to respond and how to manage some of the dialogue. And I think this really helps people to become more comfortable with talking with others of different races as equals and navigating the challenges that arise with frank dialogue. And of course, it promotes learning in this domain. So we also provided microaggression and bystander training as part of our culture change initiative. And this microaggression recognition and response and bystander training was provided to all residents, all program leadership, all resident key leadership, key faculty that is, and all underrepresented minority faculty. This was led by Dr. Cricket Fisher, and the details of our bystander program and training program is detailed in this paper that was published in the Journal of General Internal Medicine last year, entitled "Let's Talk About What Just Happened." And it's really excellent, and this publication makes it pretty transferable to others to use. We also wanted to do something to document and remediate discriminatory incidents, and specifically our residents requested a mechanism for reporting and remediating these incidents without risk of retribution. We worked for a long time on this, and we were unable to develop this in the department on our own, despite many efforts. I think the real issue was that most of these incidents were being caused by patients or staff in other departments, meaning, nurses and others, and we did not have a way to remediate these things on our own. So luckily, our hospital system took on working on this, Mass General Brigham, and they're launching this type of reporting mechanism in the coming few months. They've also been working on it for quite some time as part of their United Against Racism initiative. So the many spokes of their United Against Racism initiative are here in this diagram, and here's where they show the system-wide anti-racism, system-wide incident reporting platform being a piece of that work. Another part of the culture change initiative was thinking about what we were communicating by who we showed on our walls and in our website. So the pictures had been taken down about a year earlier from our Bornstein auditorium of all of the previous white male leaders and who had been all of our leaders. But the walls were blank. And we really felt that it was important to show who we really are today, the diversity of who we are today, and not to show just a blank slate or a blank screen. And so we have worked hard to ensure that our hospital website, our department website, and our residency website shows the diversity of who we are today and inspires others to work towards this sort of diversity. We also created a Twitter account for our Residency D&I committee, which has become a quite popular Twitter account. And here's a picture of it here. And on that Twitter account, we try to really show the many things that are happening in our department and our residency with regard to diversity and anti-racism. So here's some further reading on anti-racist culture change, a great article by faculty and trainees at UCSF. So next, I'd like to go to the largest topic within this talk, advancing diversity and inclusion. So many places are working on advancing diversity and inclusion, but I think sometimes it is seen as something that we sort of dabble at. And so I would like to tell you what I think are the critical components of effective DEI efforts, and then walk you through what we've done in this vein. So it's important to collect and maintain accurate race ethnicity data on faculty and trainees, and specifically to collect and track data by race ethnicity by key Department of Medicine segments, that is each division, the residency program, and each fellowship program. Then it's important to set specific goals for increased diversity and inclusion by key demographic characteristics, and to also consider tracking advancement as well. That is faculty promotions and advancement to leadership roles. Then we need to implement and evaluate specific programmatic strategies to reach these goals and track closely the outcomes of these interventions, and then update and improve the interventions based on feedback and their effectiveness. Finally, it is important to have a leader who is responsible and accountable for the outcomes of these DEI efforts. Ideally, this should be a senior leader with authority, influence, and who is given the necessary resources. I think one mistake that many departments make is to put some junior minority faculty member in charge of this work who has no authority and has no influence and has no funding. And I really think that, putting someone very senior like myself and giving me resources really has made all the difference for us. Also, it's important to incentivize other leaders to prioritize and make progress on DEI. And if you can do that with bonuses, as we have done, that is even better. So this is where we were in terms of URIM faculty when I started. There had been a lot of excitement that the department had finally reached 6.7% minority faculty in 2018, but there were a lot of stated plans for departures amongst those faculty. And so at the point the decision was made to recruit a vice chair, the faculty percentage of URIMs had dropped to 6%, and it was known that a few more people were going to leave. So it had dropped to 5.6%. By the time I arrived, or by the time I could see that's where we were going by the time I arrived, because of really poor retention. So these were our strategies to advance faculty diversity. And this again is specifically about faculty. We'll get to residents and fellows next. So I worked with our division chiefs on recruitments and search committees. I worked with URIM fellows to enhance their training experience and also to assist with them getting excellent faculty offers, both excellent offers and early timely offers, and to improve their retention. I also was given and utilized funds to assist with recruitment packages, say for signing bonuses, and also part of the funding for URIM faculty who we recruited. I also worked on URIM faculty retention strategies, since retention had been one of our largest problems. And these included posting all available leadership opportunities in the department, so URIM faculty were looking elsewhere to find a leadership opportunity would know of those that existed in our own department. URIM faculty and career advising and mentorship, I did a great deal of this about promotion, research funding, leadership opportunities. And I developed a minority faculty development program for all minority faculty my first year, which ran for about 18 months. And now we have one for early and new minority faculty. I also had funds to assist with retention packages, which we indeed used. And also we developed a confidential exit interview program to learn why faculty leave. And we're doing that with all faculty because we're interested in why women faculty leave as well. And then we continue to have accurate data on faculty by race, ethnicity, and gender, and we're tracking our progress every 6 months. So here's a flyer about our current program for new and early career URIM faculty. I thought this was really an important strategy since, the NIH First Awards, which had been announced and an RFP put together about a year ago, talked about cohorts of minority faculty and them coming in together and learning together and having a sense of community. We didn't get a first award at Harvard Medical School, but we did successfully recruit a good number of new minority faculty who began in 2021. And many of them had a mix of clinical and research careers. And so having this program where they have learnings together about promotion, about navigating our institution, about all sorts of important strategies in their career serves to develop a cohort They get to know each other and they learn together, and they feel that they truly not only have a place in our larger community, but have a group who they get to know well over time and can turn to for advice and input. So of note, we have a Center for Diversity and Inclusion, and each year for a long time, they've sent out goals for departments to improve their diversity. So this is what they sent to us in early 2021, that we had the right percentage of women faculty, but we were much under the national benchmark for URIM faculty, and they wanted us to get to the national benchmark of 10% by 2025. And so this goal had no teeth, but it seemed like a great jumping off point for us to begin to incentivize our division chiefs. So we asked our division chiefs to determine the number and percent of URIM faculty and fellows in their division. I just want to say again, we knew what that was at the departmental level, but we wanted them to become very familiar with it themselves and to acknowledge it. We shared the hospital Center for Diversity and Inclusion goal for our department by 2025 with them, and asked them, in light of that goal, what the goal for the division would be for the number and percentage of URIM faculty and fellows in their division in 2 years, and to provide a plan for reaching that goal over the next 2 years. A component of the division chief's bonus was linked to this set of DEI metrics that I just said, and that was for 2022. The new year's bonus is linked to their success at reaching the DEI goals that they set. We also created a council across the department focused on diversity and inclusion efforts with representation of all 22 of our divisions. All division chiefs were asked to serve on the Diversity Council or select another faculty member to represent their division. It turns out that most divisions have both the additional senior faculty member and the division chief present. And so that makes me feel that our efforts are quite, have developed a lot of energy in our department. These diversity council meetings tend to be quite large, quite energetic. The goals of the Diversity Council are to share DOM-wide DEI priorities, strategic goals, and tactics that I've developed with my team, and get the input of the division chiefs and divisional leaders. Division leaders share their D&I strategies, get feedback, and identify opportunities for collaborating with each other. So we, for example, found that 3 divisions had summer programs for underrepresented minority medical students, and so now they work together on that. We've spun off several additional committees from the Diversity Council, one focused on the research divisions, another one comprised of all the divisional DE&I committee leaders. So now I'd like to turn to what we're doing to advance fellow diversity. It turns out that because we had such poor retention of our URIM residents, all of our URIM fellows were new to our hospital at the fellowship level in general, and no one had been focusing very much on them as a strategy for increasing our minority faculty. And they tended to be the sort of ignored part of our URIM community. In fact, it turned out that no one knew how many URIM fellows we had, nor had a list. So I worked with the divisional leadership to identify all of the URIM fellows in our department. We began holding networking events for them and had one-on-one mentoring and career advice meetings with them personally. And I invited the fellows to all of our Department of Medicine URIM programming, including the minority faculty development programs. Again, you might think, well, why weren't they invited at first? Nobody knew who they were. So we had to find out who they were. We then began collecting data on URIM fellows matched into fellowship programs in 2020, and shared comparative data across the department so the divisions were aware of how they compared with one another in this domain. And then we got more serious for the 2021 match and held the first URIM subspecialty recruitment reception in 2020, which was attended by 60 interviewed fellowship candidates. And this year we held 2 receptions. We hired a junior faculty member, Dr. Chris Estiverne, to be Director of Fellowship DEI Initiatives, and we'll be adding Dr. Nicolette Rodriguez as co-director in July of this year. And as a result of this work we did, we've had our most diverse fellow matches over the past 2 years. 20% of our new fellows in 2021 are URIM, and 29% of those who matched this year are URIM. So here, Dr. Estiverne and Dr. Rodriguez, who are excited about leading this work under my direction. And here's one of our first URIM fellow networking events. Obviously the food they're eating there looks quite good as well, but really exciting for them to be able to connect across their divisions, because many of them are the only one in their division, or at least back 2 years ago. This shows our current and incoming fellows, current URIM fellows in teal and incoming fellows in blue across all of our clinical divisions. And here you can see that it's no longer the case that there's only 1 or 2 in many of our divisions, with, you can see, with cardiology with 9, infectious disease with 7, and so forth. But unfortunately, 2 of our clinical divisions, endocrinology and rheumatology, do not have any URIM fellows and don't have any coming in, but we'll be working with them and are working with them closely on new strategies to change that trajectory. Now, finally, I'd like to talk about advancing resident diversity and inclusion. So our goal was to build on the longstanding, outstanding URIM residency recruitment at the Brigham. Careful second screening of all URIM applicants to ensure that we were providing interviews to everyone who met our criteria. We developed and required unconscious bias training for every interviewer. As I mentioned previously, we ensured that our residency website showed our diversity and our racial justice work. We had more URIM receptions in this virtual time. It was wonderful that we could so easily have applicants from all over the country coming to these receptions, and an enhanced virtual second look event. And really, we worked hard to showcase everything we're doing in diversity and racial justice. We have a resident diversity and inclusion committee, and their work and their involvement has been absolutely invaluable. But I want to say that we became much more focused on URIM resident retention. And so now we're equally focused on ensuring that the experience of our URIM residents is amazing and that our environment is supportive and nurturing. And we're aiming to do that, to make sure that they have a great experience at our hospital, but also to be proactive about retaining our residents as fellows and faculty, which had not previously been happening. So as you can see here, there had been outstanding recruitment of URIM residents to the Brigham for many years. If I went back 10 years, it would look similarly. It dramatically increased over the last year, but the 15 to 18% that had been our URIM residents for more than a decade was not turning into minority faculty for us, nor minority fellows. So our goal was to create a community and an environment that would result in better retention. So it was all about inclusion. So while diversity is being invited to the party, inclusion is being asked to dance. And in fact, that was the type of environment we endeavored to create for our residents and of course for our faculty as well. So community building is key. Isolation and the feeling that one doesn't belong in these spaces is common among URIM trainees as well as URIM faculty. A key strategy for mitigating this is providing opportunities and settings for URIM residents, fellows, and faculty, even if there are few, to connect professionally and socially. So we created directories of our URIM faculty and our URIM fellows and residents so people would become familiar with who one another were. So if we saw each other in the hospital and didn't know each other, we could look each other up in the directory later if there wasn't time to introduce. And we held lots of community building events, and especially in person pre-COVID, as you can see here. Once COVID happened, we needed to make them obviously virtual. Here's a picture of our first URIM retreat that took place last year. But these events still made such a difference in connecting people and enabling them to get to know each other and building community. This year, we were able to have our URIM retreat in person. And so here's a picture at the end of it with also many of the faculty who came and taught and came to the reception at the end. And here I am sitting next to the new president of our hospital, who, by the way, was 1 year behind me at Yale Medical School. Quite a community, as you can see, and this really only has about 25% of our URIM faculty in this picture. So we also developed a mentorship program for our residents. And of course, mentors are always important, but we were finding that the sort of just send a name mentorship program that was happening for all the residents didn't stick for the URIM residents. So we became much more proactive and intentional about making the matches for the URIM residents and also following up to ensure that those connections were working. We also developed new themed mentorship communities for our URIM residents as well. And so we decided that it was important to train the mentors so that they were comfortable about mentoring across differences. And even though many of our mentors we chose were URIMs, there often was some type of demographic difference between they and the resident we assigned them to. Perhaps they were Black and the mentor was Latinx, or perhaps the resident was a woman, but the mentor was a man. So we had 2 mentoring across differences workshops to train the mentors about how to be an effective mentor to someone who was different from them. And these mentorship communities that we developed were in the areas of dismantling inequities in healthcare, community engagement and partnerships, global health, and medical education. And here's some pictures of those mentorship communities. And this enabled residents who had an interest in a particular theme that was non-clinical to connect with other residents and faculty leaders in this domain. So here's more reading about supporting our diverse residents. Great paper that came out by Monica Vella and her colleagues at the University of Chicago in the New England Journal last year. So I've spent most of my time talking about URIM faculty and residents, but last year we certainly noticed all of the anti-Asian racism happening both in our city and across the country. And as a result, our Asian residents came to me and discussed the need for an AAPI committee and also a connection to our AAPI faculty. So we've put that together. There's a lot of energy in this group. They do both political action, but they also do mentorship and community building across the AAPI community in our department. This has never been done before, and there's a lot of enthusiasm and energy about this work. So I want to just make a few comments about which DE&I goals to choose. Our department at the Brigham has chosen to focus on enhancing the representation and advancement of URIM faculty, given our suboptimal URIM retention over many years. Other demographics groups, including women, are well represented among our faculty. Meanwhile, we've also noticed that we have an underrepresentation of women and Asian faculty at the professor rank, underrepresentation of Asian faculty amongst our leadership, and as I mentioned, increasing anti-Asian racist events, which resulted in the need for support and community among Asian trainees and faculty. So these are the DE&I goals we've chosen to focus on, but other departments may choose differing goals based on their data and their needs. So for example, many departments may focus on LGBTQ D I efforts. We actually have an incredibly high representation of DE&I, of LGBT faculty and trainees. And of course, Boston is one of the most comfortable places to be LGBTQ in the country. So we have relied on the hospital-wide efforts in this domain and the medical school efforts in this domain, and really just see the need for community building among this group, and are fortunate that we have really robust hospital-wide and medical school-wide efforts in this regard. As a member of the LGBT community myself, I feel comfortable that this was a good decision for us. So I'd like to now briefly go to changes in policies and practices. As we said before, policies and practices can embed institutional racism, and we wanted to take a look at ours and see what we could change. The most important policy change we made was to promote equity is posting every single departmental leadership role to provide the opportunity for everyone to apply. So here's an example. This may have always been one that would have been announced, but it's not just announced in the New England Journal, but every single opportunity is sent out to every single faculty member so that people are not just tapped because they know the chief, but rather everyone can apply. And this, we're hoping, will further diversify our leadership and also make the diverse members of our community feel the possibility of becoming leaders in our department and our hospital as well. We also developed this guide to faculty searches, which governs the way that our faculty searches are done, which once people apply for these opportunities. We do think there's much more we can do in terms of dismantling policies and procedures that embed institutional racism. And this is an excellent paper that was written by one of our medical students and faculty about the ways that academic health centers need to change to further improve what they do in terms of equity and anti-racism. And we know that in particular, our hospital and our hospital system has a long way to go in that regard. And we continue to do our best to advocate and be activist in that regard. So finally, I'd like to talk about advancing health equity. The dramatic inequities in COVID deaths has among people of color of all types, Blacks, Hispanics, Asians, and Native Americans, has really fueled our energy and enhanced our energy around health equity. We have a health equity initiative of which I'm the director, and its goal is to advance the Department of Medicine's commitment to health equity by engaging key stakeholders within and outside the department in a structural analysis to address health inequities in our department, our clinical care, and within our community, which will inform and influence hospital level strategy. So we have a number of programmatic goals and programs, but I'd like to just mention a couple. We have a health equity initiative grant award program that provides grants of up to $40,000 total for people to work on health equity research projects or health equity clinical improvement projects within our department. We've been doing this for 3 years so far, and the RFP for year 4 is now out. The projects have been in a wide range of topics, and you can see we've had about 30 funded to date and hope to fund more than 10 again this year. We've had a number of papers come out, important publications about health equity from department members as a result of this funding, and it really has catalyzed the involvement of our residents as well as our faculty in important health equity research and also clinical transformation. We have health equity forums on a number of different topics that have also increased dialogue about important health equity issues in our hospital, including genetics, barriers to cancer care, and the EGFR race multiplier, as well as many other topics. And we had a hospital-wide health equity forum that our department was deeply involved in. So that is our framework. And really, it has been incredibly transformational for us, but we still have a long way to go. And like this paper talks about, we need to move beyond the honeymoon period and keep this work going. So in summary, we are early in our journey towards anti-racism as a department at the Brigham. We've used an anti-racism framework, which I've shared with you, which has been quite helpful. We have made much progress already, of which we can be quite proud. We have engaged and committed leadership. We've put in place numerous programs to transform our culture, and we've had numerous successes in the URIM recruitment and retention domain. the best URIM intern match in our history, the best URIM fellow match 2 years in a row. And we now have more than 100 URIM faculty for the first time, achieved both by increased recruitment, but also improved retention. But we have several important and persistent challenges. Our leadership is not as diverse as ideal. Few URIM leaders besides myself, and even fewer Asian leaders. Our URIM faculty, Asian faculty and women are not well represented at the professorial faculty rank, and we continue to work on enhancing promotions. Our framework and journey, I believe, can provide a valuable example for other departments such as yours, and hopefully inspire some additional work in this domain. I appreciate your attention, and I look forward to your comments in our discussion.
Dr. Stone.
Our department. So I'll stop sharing.
Perfect. Thank you so much. Let me go ahead and share my screen here for our QR code, like I mentioned, and then we'll start with some questions. One I had for you, just to start with, our institution and many others obviously has an unfortunately recent and difficult history of racism in our own community. How has your organization sort of dealt with getting community members involved in your work? And have you any best practices in that regard?
Yeah, I think this is a challenging issue, and I don't think any place does it ideally. I think that one thing that has helped in our hospital is we have a Center for Health Equity and Community Health, and the leadership of that center has, had the goal of connecting on an ongoing basis with community leaders, hearing from them, and having dialogue. We never have thought that this was ideal. And fortunately, when our new president, Dr. Bob Higgins, began, he basically reached out to every community in Boston and said he wanted to meet with their key leaders and hear their assessment of the Brigham and what we could do better. And while it came as a result of a new president, I think you could always do that de novo with ongoing leadership, just reaching out and saying, tell us what we could do better. The problem whenever we ask that, of course, is the willingness has to be there to actually, follow through with doing some of the things that were suggested.
Another question from the chat here. Dr. Rich asks and says, incredible work and great talk. What challenges have you encountered in advancing your agenda, and how have you navigated them?
Yeah, I think that none of them are surprising. I think the largest one for me at the outset was our division chiefs, who have many things on their plate. As many people know, we have a very research intensive department. And so they're focused on the clinical work, and they're focused on, getting lots of research grants. And this was just not at the top of their priority list. So it took a lot of time to get them interested and engaged. Ultimately, we decided to use bonuses to help with that, but it also required just a lot of meetings and chatting and the sharing the idea that incremental change made a difference, and them telling me that they had never had a fellow for 3 years wasn't helpful. I don't want to talk about history. I want to talk about how we can do better. And I think it just required just a lot of having a can-do attitude and optimism on my part, because I was faced with a lot of apathy throughout the department at first. So I make it sound so easy, I think, but it was really quite challenging at the beginning. Lots of, this is fine, but this is like number 7 in my priority list.
Right. Yeah. Getting it to the forefront is certainly important. Our chair, Dr. Frazier, echoes our thanks and says a really terrific talk. Can you describe some of your retention efforts, and what kind of different strategies do various specialties use to address recruitment and retention within that specialty?
Yeah, I don't think that they differ that much from subspecialty to subspecialty. I think that this issue of ensuring that every division chief was making every new leadership role available to everyone was important. like any very large academic medical center like yours, there's, clinical leadership opportunities, educational leadership opportunities, all those things. And they often were just handed to someone. And these were the things that had demoralized minority faculty at the Brigham for decades, and they would leave and go someplace else. And so I think doing consistently, announcing every single opportunity has made a difference. And in fact, we do see a lot of the more junior leadership roles are now being filled by junior minority faculty and Asian faculty, which was not happening before. And I think that this has worked across all divisions. We have also used small pots of funding for retention packages for junior faculty who were thinking about leaving. And then finally, while I breezed through it because I took too long, these health equity grants have made a tremendous difference. And we've funded, faculty, primarily junior faculty in 15 different divisions. As a result of that funding, $40,000 goes a long way for people who are trying to sort of keep a component of their career being in scholarship and research.
Yeah. One of my co-chiefs, Dr. Kunga, and an incoming fellow in cardiology over at the Brigham, asks, what have you learned through your exit interviews about the top reasons that women or URIM faculty leave your institution? Do you have any sense of what the reason behind their leaving is?
Yeah, so honestly, we just began the exit interview program. And so I think that we don't have a lot of data yet because we're doing it prospectively. But I actually retrospectively interviewed 10 minority faculty who had left when I first began in my role. And it was pretty consistently the feeling that the Brigham is giving us all these leadership training opportunities, but I didn't see any leadership opportunities, and I wanted to advance, and I felt like I couldn't advance at the institution. We heard that pretty consistently, and then there was also the a sense of salaries not being high enough, and this is not one that we can easily solve. We're trying to provide signing bonuses more consistently to URIM faculty, and we're working on a strategy around loan repayment, but we don't have that across every division yet. For example, primary care has a loan repayment program that we're very excited about. But we want to acknowledge the fact that salaries are relatively low given the high cost of living in Boston, and we try to do what we can to balance that problem. Certainly we are working as a department on changing the idea that when you get a leadership role, it might be 20% of your salary. We also are now trying to ensure that the salary goes up when you become a leader.
Yeah, absolutely. Dr. Spencer, I see your hand raised in the chat. I've given you the ability to talk if you want to unmute. I'm not sure if that was accidental, but well, I guess while we'll wait to see if she does, I will just say thank you. Thank you so much for your work. Thank you so much for joining us here today. Thank you to Dr. Bayani and CRE 2 for helping to bring you here. And we look forward to building upon your work here. And thank you again.
Oh, my pleasure, Dr. Hickman. Thank you all. It's been wonderful to talk with you today. Bye-bye.
Bye-bye.